What is combination therapy for canine cancer, and how did Jake do on chemo with Palladia and Carboplatin at 14 years old? Find out from Dr. Brooke Britton on this episode of Tripawd Talk Radio. Welcome, and thanks to Tripawd Talk Radio, episode number 105. And you may be watching this on the Tripawds YouTube channel, but today we're going to be talking about some innovative canine cancer, limb cancer treatments, including monthly chemotherapy for dogs with osteosarcoma. And we're excited to have Dr. Brooke Britton help us understand some of these cutting-edge therapies. Dr. Britton is a certified veterinary oncologist with a degree from Cornell. She trained at the University of Pennsylvania and practiced with BluePearl for several years. We discovered her work when a Tripawds member posted about their dog Jake in our discussion forums, and we'll let her tell you all about that and more. Thank you for joining us, Dr. Britton.
Oh, my pleasure. Thank you so much for having me.
Hey, it's good to have you here. We love hearing from oncologists on some exciting and different ways they're approaching some cancers like osteosarcoma that are really depressing when you get that diagnosis. So whenever somebody like Jake joins us and says they've been doing well for over a year at 14 years old, which is even more remarkable, we want to hear more. This is really exciting. So I really appreciate you being here. And for our audience, can you tell us just a little bit about yourself and why you decided to focus on oncology and especially really creative therapies for it?
Absolutely. From a personal standpoint, unfortunately, I had experience with cancer as a very young girl. My brother was diagnosed with a brain tumor when I was very small, and seeing him go through that diagnosis and my parents go through that diagnosis, his treatment, and everything that came along with that, and having such a love for animals from a very young age, and that interest in oncology and why cancer can be so difficult to treat, why there are different theories about how to treat it and how to successfully treat it, and how far technology and treatments have come in the past several years. I found it intriguing to be able to help companion animals as well as their people through a process like this. And so wanting to be a veterinarian since a young girl and having that experience at an early age, I think was very formative for how I chose to use my veterinary education and then my chosen specialty. So not a specialty that everyone would imagine someone initially going into because of the subject matter that we deal with, but it's incredibly rewarding, and contrary to what most people might believe, it can be a very, very happy space to be in this specialty.
I would definitely agree with that, and stories like Jake's are one reason why. Our own dog Jerry, he's the whole reason we started Tripawds, and he lost a front leg to osteosarcoma. This was way back in 2006. And we were not really encouraged to do any kind of chemotherapy with him. And when it was brought up, we just didn't know enough about it, and we opted out. He ended up living 2 years, which was kind of amazing. And yeah, it was great.
This was 15 years ago.
It was a long time ago. And at the time, towards the end of his life, we started hearing about metronomics and about low dose, regular at-home chemotherapy intervals to try to keep lung metastasis away. And over the years, lots and lots of members have tried that. We recently talked to oncologists at Colorado State, and they said, yeah, metronomics, not so much anymore. It's not really been proven enough for us to really recommend it. If people want to do it, that's fine. So up until now, we've also heard that at the beginning of the diagnosis, a treatment of 4 to 6 rounds of carboplatin is pretty standard for osteosarcoma for a dog, and even for a cat if somebody wants to go through it with their cat. And that's a whole other ballgame, but we can talk about that a little bit too if you want to explain. So we always thought it was one and done pretty much. You do that series of carboplatin treatments and that's it. You go on, you do metronomics if you want or not, and you hope for the best. So when Jake joined us, it was really interesting because he just casually mentioned that you were treating him with monthly intervals of carboplatin. So that kind of blew our minds. I thought I heard mentioned before, but not so much. So can you tell us why you decided to start doing it that way for Jake? And do you do it for other patients, or is it just particular ones?
Yeah, that's a great question, and there's a lot to unpack in sort of your background in that question. Years ago, with my own companion animals when I was a child, my vet, our local vet, pretty much was the same way. Not many options available, or not many options that we knew much about. And as the science and the medicine has become more sophisticated over the years, and we have more options and research extrapolated, and also real on the ground research in companion animals with these compounds and from human medicine, we're starting to understand that we can treat dogs and cats not exactly the same as people, but with similar drugs, and even with combination therapy, which is what I had been doing with Jake. And so to your point about his specific protocol, typically you're right that carboplatin is usually given for about 4 to 6 total treatments, usually at about 3-week intervals intravenously in a dog or in a cat with osteosarcoma, and typically after a limb amputation. With carboplatin, over time, as with many chemo and other agents, you can start to see changes in their blood counts, their platelet counts, their white cell counts. And so for that reason, and because we don't know that a maintenance type chemotherapy or long-term or indefinite chemo makes a difference in many of these dogs and cats, we pick that number to stop. We say we'll do 4 to 6, and then we monitor them. And then if they develop complications later or progression of their disease, we may restart or try something else. The reason why I chose to keep going with Jake but amend the protocol was because he actually developed pulmonary or lung metastasis. And so the concern would be that the carboplatin was enough to keep those at bay for a time, but not enough to prevent them from happening. And we saw that change on chest x-rays. Jake actually was feeling fine, maybe a couple of very subtle changes if we look in retrospect in his behavior, but generally, an excellent quality of life. But it was soon after we had stopped that initial course of carboplatin, which was initially my intent with him. And so what we did was amend the protocol by adding in a different type of agent, which is a fully approved drug called Palladia, or tesseranim phosphate is the drug name. And that's a different class of drugs called small molecule or tyrosine kinase inhibitors, TKIs. And admittedly, we don't have a lot of evidence to know exactly what is the ideal patient to combine those therapies in, what is the ideal dosage when you combine those therapies, what tumor types respond best to the combination. We know that there's a basis for treating patients across multiple tumor types with those types of drugs, alone or in combination with traditional chemo like carboplatin, but all of the data isn't fully fleshed out yet. And that sort of, again, speaks to your other point about some of the other oncologists that you may have spoken to that have different levels of comfort with using combination therapy or things like metronomic chemotherapy. Not all of the data is fully mature. And sometimes we don't have much data at all. And that's where we have to have a long and informed conversation with companion animals, people. Right? What does this mean if we start to combine therapies? What are the potential risks? What are the potential benefits? I'd be very upfront about, we don't know exactly what this outcome will look like if we combine these therapies, but I think something that I emphasize when I'm doing things that I don't necessarily have 5 published papers to point to say this is the expectation, right? Because sometimes we just don't know, and it's very individual. Sometimes it works for certain patients and sometimes it doesn't for others. But the most important thing overarching all of this is quality of life. And so as long as we are making adjustments as we go along, we're not using experimental agents per se. These are approved agents. We're just using them in a way that we don't necessarily have hundreds or thousands of patients of data to say this is the outcome we can expect to a 90-degree or 90% certainty, if that makes sense. So as long as we're upfront about that and have that conversation and we put quality of life at the forefront, I think that that's the most important thing, to make sure that people understand and have realistic expectations. And then if they want to go forward and try those options, we can change or stop at any time based on how, sorry about that, that was my text message. Based on that, we can amend the protocol as we need to, or change or stop again. And the really lovely thing about Jake was that he generally felt amazing on the combination of drugs that we chose. And in his case, it actually clinically worked very well. His pulmonary metastases regressed on the combination therapy. The reason as well, again, that we're sort of spreading out that carboplatin to every 4 weeks is that sometimes when you combine these therapies, they have an increased risk of side effect. So you may want to spread out or alter your kind of traditional single agent approach when you're combining things to make sure that it's well tolerated, and to preserve their bone marrow. Just like in people, we tend to see this less in dogs and cats, but if we use really high doses or we combine a lot of things together, that can have an effect on their bone marrow cells and the healthy cells in their body, which can become limiting or prohibitive down the line. So we want to make sure that he can continue to get treated, that he has a high quality of life, and that his body's not getting tired, so to speak, of the combination. So that was a very long answer to your question, but that's a lot of what went into kind of tailoring that protocol to him. And it's not necessarily the same exact protocol that I would use for a dog in a similar situation. It's very much tailored to that individual patient.
So when you say combination therapy, was the Palladia you added given in conjunction at the same time during the same session as the carboplatin, or alternated, or did this cause the need for additional visits, or how exactly did that look in the clinic?
Yeah, that's another great question. So Palladia is an oral drug, like many of these TKI drugs in its class. And typically a person is going to be giving this drug at home to their pet about 3 to 4 times a week on average. And that applies for both cats and dogs. Usually I start out about 3 times a week, and then I can adjust as needed. Sometimes we need to taper down to twice a week. Sometimes we need to adjust the dose. And we often will adjust the dose to the very low end of the dose range if we're combining it with chemo. And we adjust the chemo dose down to a lower dose than we would do if we were giving it by itself. In the beginning, when you first combine them, there is more potential to see changes, not only in their appetite or their energy level, which may decrease at least initially, but you can see more changes in their blood counts as well. And so we may have been every 3 to 4 weeks with carboplatin by itself, and then we may tighten it up to every 2 to 3 weeks when we add the Palladia in. In Jake's case, we were seeing him once a month when he was due for his injections, and then we were taking full blood work at that time, which sufficed for both the chemo and the oral drug monitoring. So you, over time, once you see how the body tolerates it, you can spread those visits out. But initially, they did tighten up a little bit for Jake just to make sure that he was tolerating everything well. And another point I would make is Jake's age. Jake is a prime example of the fact that he was an older dog when he started, right? He's an even older dog now. But when he started, he was enjoying and still enjoys a really robust quality of life. And even though he's older, he was tolerating these medications very, very well. So his older age doesn't necessarily mean that he's less likely to tolerate any particular drug or a combination of drugs.
I love that you said that, because so many people have told us stories where their dogs and cats have been written off just because of their age. Like, too old, don't bother. Maybe get rid of the leg, but chemo, they won't live long enough to benefit from it. So I love that you were able to say, no, wait, let's look at the whole picture here. And Jake, remind me, because his dad didn't post any pictures, and I've asked him to for this show, but was he a lab? Is that?
He's a shepherd mix.
He's a shepherd mix. Okay, okay. So
Yeah,
he's a bigger dog.
he is, and he's very handsome. He and Jake, Jake really did succeed, and continues to succeed in life in terms of his attitude. Just like humans, companion animals have a variety of different personalities, and they are individuals, right? So, it's not just statistically, do they do better with a front or a back leg, or do they do better if they're a smaller dog versus a bigger dog? How old they are. I think, all of those things take a distant second to, the personality of their person and their people, their family and support network, and their own personality. And Jake really, despite being an older dog, really had a zest for life, which continues to this day. But it is scary. You make a really good point, because a lot of people say, well, look, my dog's older. I don't know if I want to put him or her through all of these procedures and regular visits and drugs, and chemo sounds scary. I had chemo, or my family member or friend had chemo, and that sounded terrible, or it didn't work, or, I had a friend who had a dog who went through chemo and it didn't work. And the important thing is not to try to, on my end anyway, is not to try to pressure people to say, oh, chemo is right, or we must do this, or amputation is the only way. We have to come up with a plan that works for everybody. And most of all, the individual that we're treating, right, our cat and dog patients, but has to work for everybody, and everyone has to feel comfortable. And at the end of the day, even if I think something is going to work out great, everyone has to be on board. So going through that with open and frank communication with people, having a plan, and knowing that we can change a plan as things go along, I think is really important to communicate to people, because there are lots of emotions surrounding all of this, in addition to the physical and financial commitment of doing these treatments. And so, it's important to understand that people can change their mind. It happens a lot. Both ways. Some people said, well, I would never do any of these things. And then they end up doing all the things. In Jake's case, I'm just really thrilled that he has had such a great experience, and that he's successfully treated and happy, because all he thinks about, I think most of the times, is the fact that he's able to enjoy his three-legged life, doing what he wants to do.
That's what it's all about. And speaking about the drugs specifically for a second, does the Palladia come, since it's being administered at home, does it come with any certain precautions or side effects specific to that? Because when we were doing metronomics long ago, it was wear gloves and make sure you keep children away from the urine. So when it comes down to the Palladia being given at home, are there any particular precautions, and what specific side effects might be coming from that?
Absolutely. Another great question. One always has to use caution with oral chemotherapeutics or drugs like TKIs. Even though they're not technically chemotherapy, we often will take chemotherapy-like precautions. So wearing gloves, oftentimes, it's not exclusively, but oftentimes attempting not to split or crush the tablets. We don't want people to be exposed to a lot of, powder or residue from the pills. To err on the side of caution, usually pregnant women, children, or immunocompromised individuals ideally would not handle those drugs. And again, that's out of an abundance of caution. And in reality, the risk to those individuals is extremely, extremely low. In terms of normal day-to-day, if a cat is using a litter box, they can still share a litter box with their cat mates, if they have any cat mates. Oftentimes it's nice if there's a bin liner, or, certainly a scoop or some way of cleaning out the box where your bare hands are not involved, which I think most people do anyway. And with the dog, picking up excrement, feces with a bag as they normally would, or if a dog is urinating outside, there's nothing special that needs to be done there. If they're urinating on a wee pad in the house, ideally wearing gloves, or washing copiously with soap and water one's hands after they pick up a wee pad and dispose of it, is generally adequate. So most of the hygiene practices at home can pretty much remain, unchanged. There's always no issue with wearing gloves, but at the same time, most of the times, people don't absolutely have to wear gloves or put hazmat suit on to, to dispose of.
And does that hold true for women who are pregnant?
I often recommend, again, immunocompromised pregnant women, if they are handling the drug directly, to wear gloves. And I recommend that people wear gloves when they're directly handling the drug. I'm talking about the waste material, just a couple seconds ago, but when you're handling the drug, the safest thing to do and the recommended thing to do is always to wear gloves.
Okay. Yeah, that's good to know. We had that question about pregnancy not too long ago. Now you started doing this protocol with Jake when you discovered lung mets. And do you know or remember about how the mets presented? Were they one big met? Was it a couple? Was it the whole snowflake thing? I mean, is there an ideal scenario is what I'm trying to say, for starting a protocol like this? And can it be used in place of the initial rounds of chemo if somebody wanted to do that?
Sure. Again, great questions. And I believe, although I don't remember exactly, but I believe Jake had 1 to 2 metastatic lesions that we could see on plain films or X-ray, right? And so if we had done, let's say, a CT scan or a more highly sensitive test, we may have found additional smaller metastases that X-ray may not have been able to pick up. But given the fact that given that we saw the mets on plain X-rays, doing a CT wouldn't have necessarily given us any additional information to change what we do. So once we saw the metastases, we knew we had to do something different. And that's why, again, we chose to use the Palladia. And in terms of, a threshold for metastases and when I would choose this, even if I would have seen several metastases or diffuse metastatic disease, I would have still offered that protocol. I would have been more concerned in terms of outcome because of the rapidity of how those metastases developed over such a short period of time and how extensive they would have been. But I have seen dogs and cats with more widely diffuse metastatic disease that have had regression when I've tried combination therapy like this. So I still think it's worth putting it on the table.
I would say so, because we have seen a lot of people whose pets had lung metastases and they were given the option of using Palladia, and a lot of times it didn't do anything. Mm-hmm. So my question, which I don't even know if you can answer this, but why aren't more oncologists trying this? At least we don't hear about it in our community. Maybe they are, but we hear from a lot of people, and I've never heard of this.
I think, Palladia was initially approved for, and again, when I say Palladia, I mean the brand name for the drug, tissernic phosphate, right? So Palladia was initially approved for, as you likely know, mast cell tumors in dogs. And because it's fully approved, it can be used legally off-label for other species and for a wide variety of tumors. And I think, understandably and rightfully so, many oncologists are reluctant to use Palladia as sort of a catch-all for, we used standard of care, which is what carboplatin would be considered standard of care because we have much data to support its use for osteosarcoma. But, we lack, unfortunately, well-controlled prospective clinical trials using Palladia in combination with different drugs for other tumor types. And so I think, again, rightfully so, and oftentimes, not just the academic oncologists, but oncologists in academic scenarios, university scenarios, are reluctant to prescribe, Palladia for every different tumor type, because it's sort of, we try as much as we can to practice, just like in human medicine, evidence-based medicine. We want to make sure that there's a reasonable basis to believe that it could work, not just, okay, well, we'll just try this and throw it at the wall and see if it sticks because, were having progressive disease now. I think that we have enough data on Palladia. Palladia, what it does is hit different types of molecular targets that it's, in a way, it is targeted therapy, but it's not as targeted as people think. And it hits many more targets that are not necessarily unique to mast cell tumor. It hits targets that are used in signaling pathways in a variety of different tumor types. And so that's why some oncologists, myself included, will use it for many different tumor types. But I think in that sort of gray area is where communication is very, very important, because I tend to give a lot, as you can probably guess by how much I talk, I tend to give a lot more information to people. And I say, this is what this drug is in a nutshell. This is the basics of what it does and the broad strokes of what we hope to achieve. And here's the data that we have for it. And it's mainly for another tumor type, or maybe for 2 or 3 different tumor types. Right now, we don't have a lot of data to support its use here. And we might even have a paper here or there that says, we tried it and it didn't work in this particular patient population in the study, which might have been 5 dogs or 10 dogs or 15 dogs. And we know in human trials, hundreds of patients are often in those papers that are published, unless it's a very, very rare tumor type, right? But osteosarcoma is generally a very common tumor type. So I think that's the important thing to highlight. And that's why you get a variety of different opinions. It doesn't mean that I'm right and another oncologist is wrong, or the academic oncologist is right and the private practice oncologist is wrong. It just means that, you have a variety of different comfort levels. It's not a bad or a wrong thing to do. It just may not have as much data to support it. And some oncologists might say, I'm not going to do it unless I have 20 papers that say that, 80% of these patients will benefit. And other oncologists say, it's not proven not to work and it's not overtly harmful. And we know in some circumstances, both anecdotally and in publication, that it can. The important thing to note, again, is that what we really need and are always striving towards is actually putting this down on paper to give more people the confidence and the comfort level to do it by designing these trials, which is a whole other story that requires a lot of funding and a lot of other things that are for a different session.
Well, we appreciate the detailed information and the studies and being able to share that qualified information with folks. But you are not the first veterinary oncologist to show us present the spaghetti on the wall scenario. Throw it and see if it sticks. We've heard that from a number of veterinary oncologists, and it just goes to point that every case is different. What happened for Jake might not be right for Wyatt or Jerry, and they're all different cases, and we got to treat them one at a time with all this valuable information.
And I just, I will start wrapping this up because we promised you 30 minutes and I hear that you're very busy in there. So real quick, what inspires you as an oncologist to try treatments like this with patients? What drives you to kind of think outside the box, to use that cliche?
Well, I think that, in human medicine, this is really the norm. So things like combination therapy are very widely used in human medicine. And again, the difference is that the data, and they struggle with the same things that we do, but the data in large part is there with more patients in these trials than what we have. So we can extrapolate and say, we know that this can work. And in trying to push veterinary oncology forward and offering more sophisticated therapies, there has to at least at first be a basis for, can this work if we combine them? And then we have to get the data to back it up and support it so that it may or may not become standard of care. And I think that that's always what we're striving for. And just to kind of address your spaghetti against the wall comment, yes, some people view it that way. I don't actually view it that way. If I were using a completely untested, unproven vaccine that a company made and said, look, I'm putting out this vaccine, I've got minimal data, but I'm just going to put it out there. Palladia was rigorously tested in its own controlled trials for that particular tumor type. Using it off label is not necessarily the same. It's not the same as, kind of using an untested or experimental product that we really have next to no data for. So it's a little bit different in terms of approach. There are plenty of oncologists who would feel comfortable using it, but they're very upfront about the limitations of how we can prognosticate when we use it and what to expect with it, as again, that data is just not out there. And every oncologist has anecdotes and stories that they can tell you of their successes and not successes, but that's sort of how I view it. And to your point, I get inspiration every day just from my patients and wanting to do better for them. And so if there's anything that I can think of to do that is grounded in solid science and as much evidence basis as I can find, I'm willing to push the envelope a little bit, not to put them in harm's way or to experiment. That's not what we do. But thinking outside of the box is important. It's important because it pushes the science and the medicine forward, and ultimately it results in better treatment and more options for people who want to explore this type of process with their companions.
Hear, hear. I love that way of thinking. Thank you. Where can people find you?
Or are you hiding?
Well, people can find me on social media, and soon, hopefully soon in the next few months, I'll be able to either have a website or a way that people can contact me on a professional level as opposed to through my personal email and details. So it's to be continued. I live and I am based in New York City, and that's where I will remain based.
Got it.
Well, we will share everything that you've told us with people that need to hear it most. And we'll be doing that at tripawds.com and all the social medias at Tripawds.
Yeah, and we will update this this post and this podcast with your new website when it's available. So thank you for being here with us today. This is really interesting, exciting, and hopeful, most of all. Thank you so much, Dr. Britton.
Thanks for your time.
Thank you so much. I really appreciate it. Thank you.
Many thanks to Dr. Britton for the cutting-edge work she is doing to help dogs and cats with cancer. Learn more about chemotherapy, Palladia, immunotherapy, and the full spectrum of veterinary oncology treatments available in the Tripawds news blog. And join the discussion to find out about Jake or share your story in the forums at tripawds.com.